Hello class, this is the podcast on child with altered respiratory status, and in this podcast we are going to cover the concepts of acid-base balance, inflammation, and oxygenation. To begin with, let's talk about some of the variances between developmental and biological differences between children and adults. First of all, children's brain is more immature, so they do have more difficult time controlling their respiratory status. That is why we must take a heart rate for a full minute with children, because they don't necessarily, and this usually pertains to younger, so infants and young children, they don't have a normal respiratory pattern. So if you only take respiration for 15 seconds, you will not get actual accurate numbers. Also, their airways are smaller, which means it is harder for the air to get in and out. Their chest wall and respiratory muscles are less developed, making it harder for the chest to expand and contract. For example, you don't put a child in a high Fowler's position because the pressure of their organs pushing on their diaphragm can make it very difficult for them to breathe. So it does the opposite effect for children as it would an adult to help with breathing. Lung tissue, there are fewer alveoli, which means there are fewer areas for that gas exchange to take place. So younger children are definitely at higher risk for respiratory distress. And here we have the pediatric respiratory anatomy. If you can compare the reduction in an adult versus an infant, when you have a reduction of 25%, you're still at a 6 millimeter. So it only went down 2 millimeters. But if you have a reduction of 50% in the lumen for an infant, you can see you're only at you're only at 2 millimeters. So that is significantly smaller. Okay? And the thickness is definitely increased. Also, if you notice the larynx of an infant versus an adult, the infant's larynx is more difficult to assess, it's harder to perform bronchoscopies, and there are increased risks of complications, for example, increased risk of choking, because of the cone shaped. Because it goes from an area of larger to a narrow area. And this is why children have a much higher propensity to choke. That also, and they have remember, no safety awareness. So they will literally put anything in their mouth. And as you can see here, the differences in the anatomy, okay? So the most important part of your assessment findings with a child who's having respiratory issues is the history. For example, if you have a child who's having difficulty breathing and the parent said, and you can't figure out why this child has difficulty breathing, getting a good history is going to help direct you. It can be as simple as the parent saying, my child isn't sick, I turned around 1 minute and the next they were having wheezing and difficulty breathing, and now they're starting to turn pale. So now we're going to suspect choking, versus my child has been ill for a while and they woke up and they were wheezing and they looked like this and very pale. So that there's a big difference, and that was just a very simplistic example of how history is so important. So as you saw from the other picture, the larynx is smaller in relation to the body, so that proportion is smaller. The epiglottis in infants is actually harder. Also, we already talked about the larynx is more cone-shaped. So children are more likely to have obstructions from objects and mucus. Remember, when we're suctioning children and infants, it must be faster than 5 to 10 seconds, right? Signs and symptoms of upper airway obstruction include mouth breathing, loud snoring, apnea in extreme cases, stridor, and drooling. We should teach our parents preventative strategies for choking. For example, choking hazards such as peanuts, popcorn, hot dogs, grapes, coins. Alright, so we mentioned that there were fewer alveoli, so there was less area for that gas exchange to take place. There are some good links here that when you download this from D2L, you can download this PowerPoint from D2L, you can access those. If you have a gas exchange issue, signs and symptoms are going to include fever, meningitisms, which means stiff neck and headaches, so those signs and symptoms of meningitis, anorexia, vomiting, diarrhea, abdominal pain, nasal congestion, discharge, cough, respiratory sounds. So respiratory sounds include grunting, which is a sound that is made at the end of an exhalation, and it is a moaning or a crying sound. What it means is that children are trying to keep their alveoli open by creating this N sound, and it is also referred to as auto peeping. Other respiratory sounds include stridor, so that high-pitched musical sounds, sore throat, and retractions. So there is a good handout in your packet on all the areas of retractions. There are a lot of good links here for you to see what all these things are talking about, like grunting and head bobbing, nasal flaring, all those things. Remember that babies are obligatory nose breathers till about 3 months old. So if they're breathing with their mouth open, it is very bad. And remember, if we have a baby who's struggling to breathe, do you think they want to lay flat on their back? Probably not. That would probably be very difficult for them, right? So we raise their head out of the bed a little, semi-Fowlers at the most, to help with that. But again, we're not sitting high Fowlers, right? Because that does the opposite. And here's that handout, and you have a enlarged version of this in your packet, and these are all the areas that you may see retractions. But again, please download this PowerPoint and look at those videos if you don't get a chance to see them in class, okay? Alright, so let's talk about acid-base balance. Again, this is very similar to what you learned in 151, that our body has natural buffers. If we have issues with our acid-base balance based on metabolic issues, our respiratory tract will try to compensate. If we have issues with our respiratory acid-base balance, our kidneys are going to try to buffer that. Also understand that I am not going to go over compensation with you. You are going to learn about that in great detail in 250. So we will not touch, although there's some things in here that refer to that, we are not talking about compensation in peds, okay? The terms there, Hypoxemia, so that's low oxygen in the blood. Hypercapnia or hypercarbia, that is increased CO2 in the blood. And hypoxia is low O2 in the tissues. All right. Most of the time when blood is being drawn from children, it is venous samples. The advantages of having a venous sample versus arterial is there's less pain. It's one puncture. The cost is decreased, and there's a decreased risk for complications such as arterial laceration, hematoma, and thrombosis. There is an interpretation that goes along with these numbers that we will do in class. The norms are slightly different from an adult. These are the ones we'll be going off of. And again, remember, these numbers are like that. This O2 sat is so low because it's a venous sample, okay? All right, so our interdisciplinary interventions, the main goal is to correct the primary cause, okay? We want to monitor respiratory status, maintain clear airways, whether that is delivering oxygen or suctioning, those types of things. Maintain normal body temperature, monitor level of consciousness, monitor labs. So the types of labs we will probably see are CBCs. So we're going to check the H&H, that carrying capacity for the oxygen, white blood cell count. We will see maybe a CMP or a BMP for our sodium and potassium. Get a MAG to see those bronchioles are surrounded by smooth muscles, and magnesium relaxes those, so we want to see what that level is. We'll get a BUN and a creatinine, right? Love those kidneys, see what they're doing. For eyes and nose, we're definitely weighing diapers if we have an infant. Our other team members that we are definitely going to collaborate with, our respiratory therapists, the physicians, maybe advanced practice nurses, dietary, speech, social work. So if you have a child who has respiratory failure, understand that there are different types of respiratory failure. There's respiratory insufficiency. So as you can read the definition there, this is when they're able to maintain, but it's hard for them to do. Okay, and then you have the respiratory failure. So they cannot maintain adequate oxygenation. And then you have apnea, which is absolutely cessation of breathing. Okay. So at this point, you may resort to artificial airways and mechanical ventilations to oxygenate and perfuse that for your child. Treatment modalities. So again, respiratory illness requires immediate and aggressive intervention. So we're going to make sure their airway is patent. We're going to give them oxygen. We're going to use medications that we're going to talk much more about in detail, but bronchodilators, steroids, hypertonic saline. We're going to do different modalities such as multi-dose inhaler, nebulizer, maybe even an IPV, all these different types of ways to keep that airway open. We're going to use airway clearance techniques such as suctioning, and we're going to look at some other ways to have airway clearance. Artificial airways, mechanical ventilation, and then tracheostomies. Because our children are at greater risk because of less alveoli, smaller airways, and less developed muscles. So if they have a respiratory issue, it's more emergent situation. Okay? And this will conclude this part of the podcast. We will resume on this slide in the next podcast. Thank you.